Thank you. So, thank you. I would like to thank the Intraretinal Committee for the kind invitation. This is one of our latest articles from our groups. So, intraretinal fluid in intermediate age-related macular degeneration. I have no financial disclosures. As you already know, the presence of intraretinal fluid is connected mainly to a macular neovascularization, so you should treat when you see it. In reality, in literature, we have found several articles speaking to the fact that retinal pseudocysts are commonly found also in geographic atrophy, or also cysts are even observed in exudative non-neovascular age-related macular degeneration. So the aim of our study was through a retrospective study and a multicentric study, and we observed the databases from Bietti Institute in Rome and San Raffaele Hospital in Milan to observe cases of intraretinal fluid in EMD through a multimodal imaging approach. So we included patients with intermediate EMD, so with large drusen over 125 microns, and also with or without pigmentary abnormalities, with at least also medium drusen. Clearly, we excluded patients with MMV, and we excluded it through angiographic exams as fluorescein angiography, CGA, and OCTA, and we also excluded patients with history of ocular inflammation, so uveitis, but also other types of retinopathy, such as diabetic retinopathy, retinal vascular occlusion, and also with recent surgery. This is one of our cases. You can observe intraretinal cyst associated with drusenoid PED without a macular neovascularization in the angiographic exams. So we obtained 10 eyes from 10 patients, and 3 of them presented intraretinal fluid associated with a nascent geographic atrophy, and 7 of them presented intraretinal fluid associated with a PED. Interestingly, the intraretinal fluid appeared as outer retinal cysts following the LS fiber curves. So in our study, we observed mainly 2 phenotypes, one associated with intraretinal fluid and PED, and one associated with intraretinal fluid and nascent geographic atrophy. In the first phenotype, we think that the high hydrostatic pressure inside the PED is the cause of the impairment of the RPE pump due to the distance between the RPE and the Brooks membrane. In particular, the focal and local hypoxia in this particular area may lead to a release of VEGF with consequent exudation. Instead, we think that the transudation is a secondary mechanism, even though it's quite rare because we observe the SHRAM only in one case. In the second phenotype, we observe intraretinal cysts associated with a nascent GA. In this sense, we think that the dysfunction of the blood retinal barrier is due to the depletion of cells, in particular the outer retinal cells. But also we also know that geographic atrophy can also impair the Mueller cells, and so the dysfunction is maintained due to the scarce activity of these cells. So those are the 2 mechanisms that we revised. So the nascent GA brings to a depletion of outer retinal cells and then transudation. Instead, the PED brings to a blood retinal barrier decompensation and thus a transudation. So in conclusion, we revised some cases of intraretinal fluid in intermediate age-related macular degeneration, and we observed 2 phenotypes, intraretinal fluid associated with PED and intraretinal fluid associated with a nascent geographic atrophy. The next step will be the enlargement of our cohort of patients and also to observe through the follow-ups the behavior of this intraretinal fluid. And with this, I would like to thank you for your attention.
Thank you so much. We have 1 minute for a question, and actually both of us have the same question. Could you comment, please, whether do you think this atrophic changes have a role, and if you're sure that this is true fluid or just maybe just, loss of cells?
Yeah, this is an important thing, absolutely. In my opinion, yes, it's intraretinal fluid. Maybe it's just associated with the depletion of cells, but why there is, in a certain sense, a persistence of this fluid through the time? So this is hard to say. Maybe there is a real dysfunction of those cells, and so there is a persisting of this fluid that can bring this particular setting of things. But I absolutely agree with you that we have to understand more about it.
Thank you so much.
So the next talk will be by Professor